Good morning. I have straight up 9 o'clock, so let's get started with the echo. I really am happy to see you today. It is June 2nd. Where did May go? It just seems like it disappeared on us. So it is June. It's supposed to be hot today. So let's get started with the hot echo topic. Hope you all had a great Memorial Day weekend and had some time to relax and reconnect. And so we skipped last week and we're rip-rear and ready to go for this echo this summer. So thank you for attending. We really appreciate it. This is a partnership between Heartland Telehealth Resource Center and the Missouri Telehealth Network. We're offering this for providers in Missouri, Kansas, and Oklahoma, so we can address topics that may be helpful to you concerning telemedicine, technical operations, clinical, workflow, legal, regulatory, and evaluation. I'm Janine Gracie, Project Director of the Heartland Telehealth Resource Center, and I have the honor to moderate these sessions. But before we get started, I'd like to ask everyone to rename your echo screen if you haven't done that already. And you do that by clicking on your picture or your name if you're not on video, right click, and then it will say rename, and hit rename, and then make sure you put your first and last name and the state abbreviation so that we can learn from you and answer questions appropriate to your state as well. Thank you for doing that. And while we do that, we'll have the hub team members introduce themselves. So let's start with Karen.
Hi, everybody. I'm Karen Edison, and I'm the Senior Medical Director for the Missouri Telehealth Network and our Show Me Echo program. Welcome.
Great. Thank you. Rachel.
Hi, everybody. Rachel Mutra with the Missouri Telehealth Network, the Show Me Echo program, as well as Heartland Telehealth Resource Center. Great to see you today.
And Robert.
Hi, I'm Robert Stiles with the University of Kansas School of Medicine and also with the Hub Echo team today and with the Heartland Telehealth Resource Center.
Thank you, Robert. Let's see, Tim.
Good morning, Tim Davis, Oklahoma State University Center for Health Sciences Telehealth Manager and the Oklahoma representative for HTRC.
Excellent, thanks, Tim. And Heather.
Morning, everyone. My name is Heather Hagan. I'm a telehealth analyst at OSU CHS.
And last but not least, Eve-Lynn.
Welcome back, everyone. I'm Eve-Lynn Nelson. I'm PI for the HTRC program and then also a telepsychologist at University of Kansas Medical Center.
Wonderful, thank you. And Eve-Lynn's going to do our didactic this morning, so we will introduce her just a little bit later on more appropriately. And we will also let me see if the participants, if there's anybody by telephone. I see one by telephone, 713-379. Would you like to introduce yourself? Not hearing that. It might be sometimes people have their telephone and their video on at the same time, and so if it's just by telephone, we like to be able to find out who that is. Thank you for renaming your screens. Good job. Usually we do have everyone introduce themselves on this, but we're nearing 30, and I think that might take up too much time with our didactic and then the discussion afterwards. So we'll forego that, but I certainly want everyone to introduce themselves in the video Zoom group chat. So if you will hit the chat button at the very bottom of your screen, it'll pull up the chat and then you can introduce yourself that way. So name, organization, your position there, and also your state. So thanks for doing that. All right, a few things to go over before we get started. For a more interconnected environment, we'll use first names only. And so please make sure that if you have questions, there is a spot where in the chat that you go to at the bottom of your screen. If you do the pull down, and you can ask Joe Kingsbury. So you can form your question and ask Joe Kingsbury. There he is. He's waving to you from his office there, and he keeps track of all of our questions. That if you're too shy to ask, in person, that you can certainly ask that question, and then we'll go over those questions after the didactic. But really, if you want to ask the question, via video, we will certainly call on you. And to do that, you would just make sure to raise your hand, and we'll call on you, and keep your microphone on mute until you speak, and introduce yourself before you ask your question as well. We also ask that you're conscious of any confidential or protected health information during these echoes. We really don't get into much of that during this echo, but we just want to make sure that we do not spread any misinformation and or protected health information. Don't want to get in trouble there. Presentation and any of the case studies that we have will be in box. So please make sure that you check that out. And really the value of echoes in the cases. And if you would ever like to present a case, all you have to do is fill out the little form, and voila, we have a case study. And we really learn from each other during those case studies. So please think about doing that. All right, I think that covers most everything. So let's get on with the didactic. Eve-Lynn Nelson is going to be our speaker this morning, and she introduced herself, but we'll brag on her a little bit. She is the PI over several grants, including the Heartland Telehealth Resource Center grant. She's a professor in pediatric behavioral at KU Med and an expert in telemedicine. So today she's going to provide a brief didactic on behavioral health and telemedicine. I know 2 weeks ago we said that we were going to do billing, but that got changed a little bit due to schedules. And so Eve-Lynn graciously said that she would provide this presentation for us today. So I'm going to let Eve-Lynn take it away.
Super, thanks Janine. I appreciate that nice introduction. I do hope folks can join us back next week when we do have our billing and coding person joining us. She just has a wealth of knowledge, so we hope to see you back next week as well. I've been a telepsychologist at KU Med for almost 20 years, so I'm a real true believer in telemedicine. I really think it's a great way to meet children and families where they're at, be it at school or primary care or clinic. And then what we'll talk about today is really providing services to the home. I'm going to focus on pediatric telebehavioral, but I think a lot of what we talk about today applies across telebehavioral health and really across a lot of the telehealth activities across services. I want to start off just with appreciation for this team and making the ECHO possible, and then also for our teams and our partner communities that have contributed to this presentation. In this time of uncertainty, none of us have a COVID crystal ball, so we're not sure how telebehavioral or telehealth or many things are going to look in 1 week or 1 month or 1 year. I think where we've landed with telebehavioral health is just really thinking, if we follow our very best practices with telehealth, and we're following our very best practices with clinical approaches, and also following our very best administrative and business approaches, that combination, even with the unknowns, is going to set us up for the most success. You'll hear throughout this presentation the same good best communication practices that Dr. Edison shared with us earlier in the ECHO. And those are really the foundation of some of the things that we're talking about with telebehavioral health today. And then also with families under so much stress at this point, really keeping in mind some of the cultural competence and considering the patient's unique needs across age, culture, geographies, disabilities, and adapting our telehealth and tailoring it to meet the needs of that patient and family. This is just to give an idea of the kinds of services that we're looking at moving mostly from schools and primary care to the home setting. So it's really the range of behavioral health services. In our case, they have, again, been provided over telemedicine for some period of time, but it's a newer thing providing them to the home. So we've translated our family and behavioral therapies to the home-based setting. So things like PCIT, psychological strategies for behavioral concerns, trauma, and chronic medical conditions, our behavioral strategies for autism and co-occurring concerns. Also translating our medication management and consultation services to the home. So our telepsychiatry colleagues and their behavioral medication management to the home. Translating some of our parenting and prevention strategies. I really like to mention OASIS because it's a pairing of online learning and telehealth. So it's a really nice pairing to help support families in the home with adopting some of the parenting and behavioral best practices. We were also working to translate our feeding clinic and our pediatric obesity clinic, Healthy Hawks, to the home. The toileting clinic, this one, it really came about with our school nurses saying, hey, we really need to address some of the toileting concerns. That's what I see children in my school being teased and bullied about. And it's been a real success in the school setting, but we're also seeing that that clinic translates really well to the home environment. We're also translating our behavioral assessment clinics to the home. So autism assessment, functional behavioral assessment, and then with a newer project, the Kansas Disaster Outreach Project, the project was intended to focus on some of the traumas and post-trauma after natural disasters, so flooding, tornadoes, all that. But we're really updating that project to more look at pandemic-related trauma and really looking at how do we deliver those services to the home. So with all those services, what I'm going to talk about with the majority of the presentation is how we approached and made families comfortable and ready to receive the telebehavioral health services in the home setting. So with our telebehavioral at home planning, really taking a proactive approach and really looking at it as continuous improvement. So the idea that we're all in this together, there's going to be some bumps and hiccups along the way, but if we're all, talking with the providers, talking with the patient, then continuing to improve our home-based services over time. As I mentioned before, we're really encouraging the range of our professionals, psychology, psychiatry, developmental medicine, social work, all those sets of providers to look at their professional organizational guidelines. It's been very fortunate. There's lots of telebehavioral health training opportunities at little or no cost, which has been a real help. And then for folks who are newer to providing telehealth services, really looking at some ongoing mentoring from folks who've been providing telehealth for some time, especially with the rapid adoption to the in-home setting. We, with the planning, thought through the patient appropriateness for in-home telehealth, weighing risk and benefits, considering risk associated with an unsafe home environment, as well as risk of medical emergencies, considering the risk of in-session elopement, aggression, self-harm, or any potential unsafe behaviors toward the child. With our providers, we've also focused on discussing and documenting emergency procedures as part of the informed consent. Just really checking in with families about their local emergency resources and contacts, considering the release of information in some cases for a contact who could assist during an emergency, and recognizing possibilities of delays in emergency response due to rural or remote location. And mostly the idea is just really planning ahead with the family. We also have encouraged family support plans. We have some templates for the family support plans. This is really to have families have in their back pocket ahead of time a plan for coping, looking for triggers or warning signs of distress, and what their strategies are. We also have provided families ahead of time with tip sheets. So the idea is really, helping the family plan ahead, be it where the session will be held in the household, as well as what to expect. The idea with the tip sheets is no surprises. Talking with families ahead of time about, how can we make this the best use of the family's time and maximize our time together. We have thought quite a bit about cross-patient language needs, providing simple instructions, and whenever possible, doing a test connection ahead of time with the family, checking power cords, checking the computer before the telebehavioral health session. It's things that kind of we all know to do, but then, when we're in the middle of it, sometimes we can forget, both on the provider and the patient side. And then really encouraging families to choose a safe room with a door when that's possible. That's not always possible, but helping families think that through ahead of time where the best possible space is. And then ahead of time discussing potential costs to the patient. And this really includes costs associated with connectivity. Again, in the spirit of no surprises, really helping the family think through, what part of my data plan may this use, and can the family afford that cost. Again, these are the do's and don'ts from our tip sheets. Again, ideally discussed with the coordinator and roomer ahead of the visit. So the do's are things like join in a quiet, private place, participate and ask questions. This one is one that's come up a lot is just, not roaming the house with your tablet or phone, but really finding a spot and putting your device on a stable table or other surface. Again, to help me, the provider, hear you the best and help us work together. Things like keeping your camera on the entire time, having both the parent and the child available. That's one that's come up a lot in our behavioral services, where the parent is come to the session, but then the child is still sleeping or not present. So having it be the expectation that both parent and child are available. We do ask that families can think about the visit just like an on-site visit. So, not coming in your PJs, but coming dressed and ready to connect for the telebehavioral health service. Some don'ts we have are things like, don't hold the tablet or phone in your hands and move it around. Don't join in a public area. In other projects, we have had a group of folks try to connect from outside or McDonald's or a nail salon, all those kinds of things. Less so now with the in-home, but really just having reminders ahead of time about how to maximize privacy and confidentiality. We ask that you limit the siblings and pets in the room, you know, turning down the music or TV in the household, not eating during the sessions, and then as we talked about, the not roaming the house. And then in terms of setting the stage, as the provider talks with the family, really reinforcing best safety and privacy practice, just as an on-site clinics, sharing whether the session is being recorded. And then as Dr. Edison talked to us about earlier on, really monitoring your own image and your volume. She made the great point that sometimes folks new to telehealth are prone to be talking extra loud. So just really monitoring that on screen. Talking with families just as we would on-site about confidentiality and its limits. Just for our providers, just reminders about following all documentation best practices, having that family callback telephone number and emergency service documented ahead of time. So if there is a concern, the provider can feel confident in reaching back out to the family. Minimizing distractions in our provider work areas and encouraging patients and families to do the same. As much as possible in the home environment, considering the lighting and space needs. Again, checking the video screen to make sure the patient's able to see your facial expressions. And then if available, using the picture-in-picture feature to allow you to see yourself and the patient at the same time. In terms of introducing the session, again, we really aim to do things similar as we would in person. So to encourage rapport, you know, approaching it as a conversation, whether it's commenting on, you know, the Jayhawk shirt or the Mizzou shirt, or, you know, whatever the child is into, you know, having that same connection and welcome and conversation. Asking if the patient has ever met with a healthcare provider over telehealth, and talking about expectations, and also sharing at the beginning of a session, you know, what's the goal of our session today? Is it a brief check-in to see, you know, to continue to do well, or is it a full therapy session? And just being transparent about that goal. Explaining to the patient why telehealth is being used, as appropriate, you know, reviewing information about mandatory disclosures, planning ahead for technical difficulties and having technical support throughout, and then finally providing patients and families the opportunity to ask questions. And in terms of keeping engaged throughout the session, things that our behavioral providers have found helpful in engaging families to the home include things like sharing handouts and work with them. So sharing your Zoom screen, using other features like the whiteboard feature, and then, you know, with the tip sheets, also thinking through, with younger children, it may be helpful to have a toy available, and thinking that through ahead of time. We do sometimes consider slightly exaggerated expressions to engage the child and family. So, you know, virtual high fives or thumbs up, some of those things really to keep a child and family engaged. With younger kids, the home is a great place to talk a little bit about their favorite things, and let them show that off to you in terms of, you know, their favorite toys and books and those sorts of things. And then with older children, you know, talking about hobbies, journaling, music, all those kinds of things. Across kids and adults, the one thing we often see is families wanting to show off their pet. So we've seen a lot of dogs and cats and turtles and butterflies, but it's really a neat way to engage with the child and the family. And they're often just so proud to show you their pet. And then if the patient's having trouble remaining in the frame, you know, considering talking with the caregiver and having the child return when it's a time to focus on them. So just an overall take home, I hope what you've heard today is that telebehavioral health research findings in general, you know, to the home, by and large, there's more similarities to in-person care than differences. Right now, there's so much interest in, of course, addressing the behavioral health concern, but also just supporting children and families, you know, around online learning and the changes in their routine, and just providing a lot of practical supports during this challenging time. With home-based services, there have been some barriers and challenges, mostly related to less control of the home environment. So you've heard a lot today about safety and really thinking about any kind of risks that the family may face, but also there's practical solutions, you know, joining together and talking together can address some of the safety concerns. There's patient lack of access or unfamiliarity with the technology. Really with our young folks and families, often they do have experience with technology. You know, they've Skyped with family or their grandparents. They've used technology in other settings, but with families who haven't, you know, building in the technical support. And then just a recognition that our families and our providers are juggling many work-home responsibilities and you know, providing both as much support as we can. Some things that have really helped and are facilitated connecting to the home environment. Again, the patient's pride and excitement in sharing things. It does give the clinician a better picture of the home environment and help them tailor interventions. And then there's also great opportunities to use the home environment that may be therapeutic. An example of that is we've been working with a child with a phobia around vomiting because they had vomited in the household at one point. So being at home has really helped with some of the coaching and exposure response therapy that we were working on. So again, the home offers some unique positives with some of our behavioral strategies. And then just so that including trainees as much as possible, I think as we've seen the huge need for behavioral health to our rural and remote sites, especially during the pandemic, as much as we can, including trainees and everything we're doing. Workforce for us is really the elephant in the room where we have the need, but we always are challenged to find behavioral providers. So, and the trainees really have loved the opportunity to see patients to the home. And then I just wanted to close with some of the overall COVID-19 and telehealth resources that our behavioral teams provide to family. A lot of these can be found at the COVID-19 link on our telehealthrocks.org website. So it includes parent resources, child resources, educator resources, and provider resources. There's several apps that our providers are using with families. A couple that are popular right now and are based on evidence-based principles include COVID Coach and Virtual Hope Box. And then the picture on the right I think it's a fantastic workbook that's free to families. That link can also be found on the telehealthrocks.org site. It's just a really practical workbook of, really fun activities for the parent and child to engage and help support one another. In another hat, we're also doing quite a bit of telehealth and resilience training for healthcare teams. There's some resources related to that topic. And then finally, I hope some of you are excited about telebehavioral health. If you're looking at ways to start or extend services, I know folks across Kansas, Missouri, and Oklahoma would love to talk to you about telebehavioral health, or really across telehealth services around some of these implementation topics. So thanks so much for the chance to talk together today.
Thank you so much, Eve-Lynn. I think we have a couple of questions that came through the chat, and Joe has been keeping track of some other questions. So let's get started with some question and answers. Joe?
Sure. Thanks, Janine. Good morning, everybody. First question to come through from one of our participants is for Eve-Lynn. Do you find the families like the tip sheets in hard copy or electronic form?
I think it's a yes and yes. I think we found, it really varies family to family. So we've provided them in both ways. And then I should say in our first sessions, we also share screen on the tip sheets and go through together. So it's been helpful to have both.
Thank you. Next question for you as well. Have you ever considered using an avatar in a non-clinical session to engage the child and get them to engage in the technology, or use an avatar as an incentive for engagement, again, in a non-clinical interaction?
Yeah, thanks for that question. I think it's a super cool idea. We haven't used it as much in our clinical practice, but I have seen it used in really innovative ways. There was a program near St. Louis, I know, using avatars with some of their substance use disorder treatment, and it was really a super cool way to engage folks in a private, confidential way. Some other programs have used avatars, with teaching, for example, children with autism and working on social skills in the virtual environment, which again, I think is a super cool approach. And then I've also seen the avatar, this is a little beyond this question, but I've also seen avatars used in cool ways to train our providers. University of California, Davis, they did some work around creating a virtual environment to simulate, what the patient may experience in a psychotic episode or a depressive episode, and then the providers join as avatars into that virtual world, really to more get an understanding and appreciation of what the patient experiences.
Thank you. Janine, that's all the questions I have in my queue currently.
Okay, sounds good. Do we have any other questions that you would like to ask out loud instead of typing it in? We're all for that. And questions that you might have just on any topic about telemedicine, as we're here to all just learn from each other. Everybody's quiet today. Don't be shy. Eve-Lynn, I'm wondering a little bit more about perhaps with COVID going on and more people are sheltering in place, and there's a lot of togetherness If I know that domestic violence numbers go up in times like this, and was wondering if you have any advice for those kinds of appointments that may have a parent or a spouse or that type of thing not wanting to participate, or you know, maybe it escalates during the appointment. If you might have some tips about that, about seeing telebehavioral folks from their own home and it escalates.
Sure, that's a great question, Janine. You know, we try to look at some of the patient appropriateness and just as much as we can do some things proactively, especially if there is someone with a history of abuse who's in the household. But best plan, some things can come up unexpected, just like you're describing. I think what we try to do in that situation is really use some of our best calm down strategies to really focus in on what's best for the child. And, you know, especially if it's to parents who are having that disagreement in the home, you know, refocusing their interest into the, you know, the interest of the child, and why are we meeting today to work together to advance the interest of the child. If you're truly concerned about the safety of the child or parent, you know, we have talked ahead of time about mandatory disclosures and connecting that family with you know, law enforcement or other resources if there is a threat to the child. I think sometimes just focusing in on the now and helping the folks who may be having conflict focus in on the now about some of the things that they can do, and using some of the mediation skills to talk through, you know, it's hard for me to listen to you when your voices are raised. You know, I need you to stand here and you to go over to the other room right now. Being pretty directive around that can also be some things that we use to try to de-escalate a situation. Are there things that others on the call have utilized or recommend when they have had conflicts over the telehealth system?
I'll share here in Oklahoma, it's not directly with the families, but for several years now, we have had our law enforcement that has statewide implemented what is a 10 questionnaire lethality assessment when they go on a call to determine the risk, and then share that with the potential victim of their risk of lethality of the situation. And I haven't got an update, but they were in the process because they were using tablets where they would either step outside or sit in the patrol car, where they could, depending on the immediate scoring of the lethality of that situation, have the potential victim video conference with a safe house or with a shelter or something to have that face-to-face contact if they needed that next step of reassurance to go there, and that comfort level of going there, to help them just be a little more comfortable in leaving that situation and going on. Fascinating to me is, while it started out as a research project at the University of Oklahoma Health Science Center with our College of Nursing, and specifically with a faculty that intimate partner violence was her area of expertise and was nationally recognized. And she put it out as a research project to see if this really did give them data and change situations and recommendations, because the law enforcement in the first 3 months found it so successful of reassuring to their officers that they had an additional tool to potentially help. They implemented, and it has state legislation that it was implemented statewide. And I remember with the faculty saying, no, we can't do that. We don't have the research data to support that. And I said, No, they find it valuable. No matter what your research data says that it proves, they find it as a tool for them and their confidence level of working with those potential victims. So let's see if we can't help add that next layer of telehealth or video conferencing, and then they're more comfortable as we can, adding that just exactly as you're saying then for those next steps directly with the potential victims and counseling or whatever it might be. That reminds me, because I need to have a follow-up. I haven't talked to them in a year or so. I need to see where they're at and what they've proved is working well or working not. But that I know is being utilized across Oklahoma and was one of those levels of support that we found was very helpful.
Yeah, really, it sounds like a model program, Candace. So thank you for sharing that.
Yes, thank you. Very good. Joe, did you have a question that's popped in?
I do actually. A few have rolled in during this conversation. Very good conversation, by the way. Next question is first a statement. I really liked your tips sheet, superb. And the question is, at baseline, I really don't like talking on the phone or FaceTiming with friends. Much prefer to be in person. I realize this is making telehealth for me feel very arduous. Any suggestions for coping with that?
You know, I appreciate your honesty. I think that's some of us connect one way or the other. So I think that self kind of knowledge and honesty is super helpful. I think, again, knowing that you may meet with the patient and client in some point in the future and thinking about that and connecting that way, you know, that sometimes helps kind of keep in focus that, you know, at some point I will meet you in person. I think some of it may be practicing and also reaching out to others who are providing telehealth, kind of thinking through, you know, what I really enjoy about meeting in person is, you know, I can, you know, share kudos in a certain way, or I can connect, or thinking about how to use those same things that you really enjoy in person and translate that to telehealth. I think it is different over telehealth, but kind of in thinking about how to translate that, sometimes it can kind of lead to, you know, new and not the same, but good ways to connect. And like I say, I just learned so much from my colleagues when I talked with them about how they're connecting with kids during this time. So if you have other colleagues you can chat with about their approaches and share yours, I think that can be really helpful. I don't know if others on the call have ways that they've connected.
I'd like to just kind of get a little barometer taste here in terms of anyone who is doing telebehavioral health right now, whether it's with adults or children. And if you go down to the bottom of your screen, you'll see there's a little reaction button. And if you click that, left click that, you get kind of a thumbs up icon. And so if you are doing telebehavioral health via telemedicine, would you kindly click that little thumbs up button for us? All right, very good. Thank you for that. So we do have some people who are on here that are doing the work right now, and we can certainly learn from each other. So thank you for helping us out with that. Joe, any questions?
Yes, next question. I've had a telehealth visit for an asthma follow-up. Both the mom and child were present, but the child was on his screen for the entire visit and didn't really participate. Do you recommend asking the family to put the screen away during the visit, Or what are your recommendations? The child was present for the visit, but not involved.
Yeah, for sure. I think some of the kind of preparation ahead of time, so kind of in preparing for that next visit, you know, just talking about joint expectations. I think for some of, again, more some of the school age and teen patients we see, you know, we will sometimes talk about, I'm asking you to put your screen down, you know, for our first 30 minutes. If we're successful at that, then you can check, you know, then we're gonna end the time early for you and you can have some time for screen time. So whenever possible to, you know, incentivize, you know, you've done a great job being off your technology for, you know, whatever period of time. So, you know, this is what you get back at the end to be able to engage in the technology. But, you know, I think that's a hard one where it really is more looking toward the next appointment and setting up those expectations.
Okay, next question that I have, and then this is a timely one. Do you have any suggestions for helping families that are dealing with the recent events concerning police brutality and the horrific videos that are being played over and over in our homes?
You know, I think this is more just a general child behavioral response. I think the strategies we really want to reinforce are limiting the media exposure and being mindful of all the ways children are getting media exposure, and really, you know, having the family feel confident in saying we need to limit some of that. And then having a time the family can talk together about, you know, what does this mean in the family, and having that be a part, you know, if media is involved, also watching that, you know, or more talking about what's in the media together with the parent or guardian and the child. I think also talking about routine and having kind of expectations for the child and parent, even during this very stressful time, including stresses around some of the brutality that we've all witnessed. You know, focusing in the family on some of those things that we do know are protective for the child, you know, the open communication and routine. The resource I shared from Annette LaGreca, the one around where it's the child sitting on the shoulders of the adult, it also has a lot of good tips around just mitigating trauma and exposure to trauma. So I also would recommend that resource.
Thank you for that. Very timely question.
Janine, I'd like to go back to one of the earlier questions. It reminded me that one of my colleagues in Topeka is doing some really good work around child custody and the mediation in child custody over telehealth. It might be an idea for this group too, where he's recently published something in that area, and how do we use our best child custody practices for evaluation over telehealth.
Ah, very good. Yes, that sounds very interesting. All right, Joe, any other questions?
That's it on my list.
All right. Any other questions that you would like to bring before the group? All right, June, hot day in June. We're just kind of hibernating today a little bit with some of our interaction, but hey, it is Tintel. And so we're going to practice our way to avoid Zoom fatigue and let you go a little bit early today. I do want to remind you that next week we will be back at 9 a.m. Tuesday, June 9th for the billing and coding presentation that we've been promising you for a few weeks now. So, but we've got it on the calendar and it will happen, I promise. So please join us next week and go out and have a wonderful day. Thanks for joining, everyone. Bye.